All right. Well, good afternoon, and thank you, Amir, Steve, and all of the Seattle Science Foundation for the invitation. Always an honor to be here, and looking forward to sharing with you guys coronal imbalance in adult spinal deformity, kind of the lost, the stepchild of deformity, but I want to talk to you about why it's so important. So really the coronal plane is where it all began. So our major deformity organization, the Scoliosis Research Society, is on scoliosis. So the coronal plane, particularly in pediatrics, is where a lot of where deformity principles and discussions arose. And much work has been focused on defining regional deformity in the coronal plane as measured by the Cobb angle and associated disability, but also how to indicate operations based on this regional deformity. Also, understanding the overall coronal alignment is important. You can see here it's the deviation of the C7 plumb line, the turquoise vertical line relative to the CSVL, central sacral vertical line, the vertical red, and then how these in combination with each other affect just overall cosmesis, shoulder height, rib, and pelvic obliquity, et cetera. And the majority of treatments initially were focused on correcting the coronal plane, as you can see here. But we started to realize that in 1980s, 90s, that the sagittal plane was really a major driver of disability. But it feels like this pendulum has swung over the last 5-10 years or so. And really this is because of the associated disability with the coronal plane. If we look at Glassman's original paper in 2005, you can see here that preoperative coronal malalignment greater than 4 centimeters was associated with greater pain, functional disability as assessed by the ODI and the SRS-22 relative to those who had less than 4 centimeters of global coronal malalignment. More recently in JNS, the ISSG demonstrated that a residual coronal malalignment globally greater than 3 centimeters was associated with a worse outcome. And they suggested that this was a potential coronal realignment target threshold to assist surgical planning. The ESSG, more recently in 2023, felt like that threshold was a little bit tighter. And they found that coronal malalignment independently affects patient-reported outcomes greater than 2 centimeters of offset, and disability thereafter increases linearly. Again, from the ESSG, they found that coronal correction of the coronal malalignment less than 2 centimeters allowed for significant improvement in SRS-22 and SF-36 scores, and was associated with a 3.5 times greater odd of achieving MCID on the SRS-22. So just as a summary, coronal realignment targets, I think these are reasonable. Shooting for a CSVL less than 2 to 3 centimeters. You want to keep the shoulders parallel to the horizontal of the floor. And part of this can be achieved by balanced correction of the scoliotic curves. I think we're all asking, well, how do you put this into action? How do you plan for operations to achieve appropriate coronal malalignment? And it's really important to define what the intrinsic pathology is, so within the spine, but also understanding the extrinsic pathology, mainly leg length discrepancies, and we'll talk about that shortly. So starting with intrinsic pathology, I think there's 2 classifications that are important to understand, and they complement each other. One is the Bow classification, as you see here. It's a 3-part system. As you see, and it's based on 2 factors. One is magnitude of coronal malalignment, and then the trunk shift relative to the convexity or concavity of the lumbar curve. So you can see on the far left, a type A are those patients who have less than 3 centimeters of quote-unquote malalignment. Those that are type B or C have greater than 3 centimeters, but they're differentiated based on their shift of their trunk. So type Bs, the one in the middle, have their trunk shifted ipsilateral to the concavity. And then the type Cs, on the far right, have their trunk shifted to the convexity. And we'll talk about why this is important because it really dictates surgical management. When I was a fellow at WashU, we looked at all of the patients. And this was a unique patient population because it was all posterior-based operations with or without TLIFs. And we looked at how patients started preoperatively in terms of the coronal alignment based on the BOW classification, A, B, or C, and then looked at how they changed afterwards. And for the type C patients, you can see that 2/3 of them, 67%, remained malaligned in the same direction. So these are the problem children. These are the ones that are very, very challenging to correct. It can actually get worse afterwards if you don't employ the right surgical strategy. These are a couple of images from the paper. This is a patient, you can see here, BOW type C, trunk is shifted to the convexity of the curve, 6.5 centimeters, pretty significant lumbosacral fractional curve, 40 degrees, mid-lumbar curve, say moderate, 45. This was treated with just a posterior-based operation, and really there wasn't much achieved in terms of correcting the mid-lumbar curve or the lumbosacral fractional curve, and this patient stayed malaligned in the same direction. Another patient, BOW type C, 4.5 centimeters or 5 centimeters to the right, ipsilateral the convexity of the curve, more significant mid-lumbar curve at 55 degrees and 40 degrees lumbosacral fractional curve. L3 to S1 TLIF and a T4 to the pelvis. You can see that the coronal malalignment got worse. And the reason for this was because there was an imbalance in the correction of the mid-lumbar curve relative to the lumbosacral fractional curve. Relative home run of the mid-lumbar curve, they improved the lumbosacral fractional curve, but it the balance of the two corrections wasn't adequate. And then this is another patient population that we'll talk about why the second classification we'll talk about is important. And these are the BOW types A's. Technically, this patient is not malaligned preoperatively, but you can see that the trunk shift is already going towards the convexity. And these are the patients who can get worse because they're really a BOW type C that's being hidden. And after undergoing an L5-S1 TLIF with pretty significant correction of the mid-lumbar curve, this patient went from being quote-unquote aligned preoperatively to very significant decompensation afterwards, 8.5 centimeters to the right. Again, I think they employed the wrong surgical strategy here. Now, in terms of deciding on the right surgical strategy, Obaid in 2019 proposed this two-part classification system. And this is really only dependent on the trunk shift relative to the concavity or convexity. It doesn't have anything to do with the magnitude of deformity. You can see here on the far left that the type 1s, the concave, are the equivalent of the BOW type Bs. And then on the right, the convex, or the type 2s, are the equivalent of the type Cs of BOW. I put the A in the middle because BOW A can be either a type 1 or a type 2. And when we talk about correcting these deformities, it's important to understand the flexibility. And flexibility in the coronal plane can be assessed by a lot of factors and methods, as shown here: bending radiographs, standing or supine, push-prone radiographs, fulcrum bending, static and dynamic supine radiographs, and then, as mentioned in one of the prior talks, scout images of a CT scan and supine MRI. I'm a big proponent of the scout images of a CT scan. This is a patient of mine, pretty significant coronal malalignment, standing in the middle image, and on the right, her lying down corrects significantly. So this is important, especially with assessing the Obaid classification, because a flexible deformity can be assessed or addressed via the disc spaces, where a rigid deformity often requires a 3-column osteotomy. So for the type 1s, the ones on the left, Obaid has recommended that correction mainly be achieved through the mid-lumbar curve. For the type 2s, the lumbosacral fractional curve should be where all of the action is performed. So let's put this to the test and we'll go through some cases. So this is for the Obaid type 1, the BOW type Bs, correction should be through the main lumbar curve. Assessing flexibility, posterior column osteotomies, these are the ones that if you want to do an interbody, anterior to psoas, direct lateral interbody fusion, very reasonable. And then if it's rigid, a 3-column osteotomy or an intradiscal osteotomy can be employed. And then the lumbosacral fractional curve of these, at least in the coronal plane, is somewhat secondary. So this is a patient of mine, Parkinson's disease, pretty significant decompensation in the coronal plane, a BOW type B or an Obaid type 1, and we want to focus all of our correction in the main curve. When we look at the CT scan, supine, a lot of air in all the discs. This is a relative flexible deformity, so we're going to be performing some intradiscal work. And for this patient, we did an L3 to S1 ALIF. We did structural interbody cages from 4 to 1 to help restore the lordosis. And then at L3-4, I'd like to just do a release, put morcellized graft, no structural cage, because I don't want to fix that obliquity through 3-4. And then on a staged day, we did a T3 to the pelvis, and we put a kickstand rod on the right to help correct. And I think overall, we were able to achieve our coronal correction. Another patient of mine, mid-70-year-old lady, prior L4 to 5 TLIF, and presented with this very, very severe coronal decompensation to the right. Again, the trunk shift is ipsilateral to the concavity of the curve. And so this is an Obaid type 1 or a Bow type B. And we want to focus all of our correction on the main lumbar curve. Looking at the CT scan, you can see that there is some fusion through that L1-2 disc space, and that's really the location of and the driver of her deformity. So I consider this a rigid deformity. Now, you could do a 3-column osteotomy here, but a PSO at L2 is not really the ideal location, especially for the sagittal plane. And so there are other ways to release this area. You can consider doing an ATP, a direct lateral, but the thoracolumbar junction for lateral-based operations is a little more challenging, especially with the cruce of the diaphragm, and that anatomy can be challenging. So for this lady, we did an intradiscal osteotomy posteriorly, but before that, an L3-4 and L5S1 ALIF, more for the sagittal plane, and then just put an osteotome within the L1-2 disc, broke up that osteophyte, was able to distract segmentally across it, and was able to, I think, achieve adequate coronal alignment. Now moving to the type 2s, Obaid or the Bow type Cs, these are the patients that are more challenging to correct. And based on Obaid's recommendation, all the focus should be at the lumbosacral fractional curve. Again, assessing flexibility. If it's flexible, inner body work can be done to achieve this. And if it's rigid, a 3-column osteotomy is needed. For these patients, my words of wisdom are I would avoid structural cages here. So these are the ones that I'd recommend against doing an ATP or direct lateral because you'll decompensate them to the right. And this is something that Eastlack showed on that other patient of his, and bringing them back afterwards can be quite a bit more challenging. And then for these patients, I always set up a kickstand rod ipsilateral to the convexity. In terms of what's the best way to correct the lumbosacral fractional curve, we did this systematic review last year looking at ALIF, TLIF versus nothing, and we found that the literature is not great, but ALIF and TLIF, so any type of inner body work is better to no inner body for correcting it, and then there's limited level 3 evidence that ALIF is better to TLIFs. I like ALIFs, I'm biased towards that way, not just for the coronal plane, but I think it restores your L4 to S1 TLIF, L4 to S1 lordosis better, helps correct the pelvic tilt, and restoring that 4 to 1 lordosis is very key, I think, for setting a good foundation in the sagittal plane. So going back to that patient, for this, we did a L3 to S1 ALIF, again, structural cages from 4 to 1, cancellous chips at 3-4 to help release it. And then we did a T10 of pelvis with a kickstand rod on the right and brought her back within the 2-centimeter threshold. And then this is an example of a patient who I think it's important to really assess the supine images for. So this is a lady with a neuromuscular scoliosis, myasthenia gravis. And if you just look at her standing radiographs, you consider her an Obaid type 2 or a Bow type B. But if you look at her supine CT scan, you can see here that really she falls into the type 2, where her trunk shift is ipsilateral to the convexity. So for this one, we really want to focus on that lumbosacral fractional curve. I want to correct that 4 to 1, bring 4 back over 5. And so for her and for the main curve, again, if you overcorrect this, she's going to be way decompensated to the left, and she's not going to be happy. So for this, we did, again, 3 to 1 ALIF, 3-4 morcellized chips, 4 to 1 structural cages, and then a T3 to pelvis with a kickstand rod on the left side. And overall, the curves aren't corrected perfectly, but they're balanced, and then that achieves the global coronal alignment that you're looking for. Now, I've talked a lot about the kickstand rod, and it was brought up earlier. I think it's a technique that's been written on a lot. I think it's very important to understand its utility, but also how to perform it. And so I'll just go through a quick step-by-step on tightening set screws, loosening, which ones are done first, last, et cetera, to help guide you intraoperatively. So you can do this before you assess the overall alignment or afterwards, depending on if you're happy or not with your coronal correction. So once you've put your iliac, traditional iliac screw in on the side that you want to do it, and you put W connectors at the thoracolumbar junction. I used to use one, but now I use two because I think the amount of tension that's placed on one, I don't want it to slip post-op, so I put two. So what I'll do is the green is going to be loosening. So everything below those W connectors at the thoracolumbar junction, ipsilateral to the kickstand rod, are loosened. Proximal to that are tightened. You then want to tighten that traditional iliac screw that's for the kickstand rod. You then tighten all the set screws on the contralateral side, and this helps fix your lordosis. And then you loosen the set screws that are on the W's. You then put a rod holder a little bit distal on the accessory rod on the kickstand rod, and then you distract on it. And effectively that depresses the pelvis. It doesn't push the trunk over, it depresses the pelvis. And two things to understand is that when you're depressing the pelvis, it's going to shorten that kickstand rod on the W's. So you want to make that accessory rod or the kickstand rod long so it doesn't shorten too much and you lose your correction. And then on the iliac screw distally, or the connection to it, you want to also keep that rod long, because as you push that pelvis down, that rod is also going to shorten. And if you don't make that rod long enough, you won't actually be able to do the kickstand rod technique. When correcting the lumbosacral fractional curve with or without a kickstand rod, there can be stretch on the nerve roots, the distal nerve roots, and the Columbia group led by Lanke put out some measurements that may increase the risk of developing a neuropraxia, measuring from the L4, L5 pedicle to the femoral head, and the thresholds he put there. And then other caution with using a kickstand rod is that it can be a very powerful tool. If you even distract a little bit, it's going to improve your coronal alignment a lot. And I show this case, a patient of mine who I think I overcorrected, thankfully not too much, but it did result in some overcorrection. So you can see pretty decompensated, 11.5 centimeters. And we did the kickstand rod and pushed her over the other way 2.5 centimeters. Her shoulders are balanced and she's within that 3 centimeter threshold. So overall she doesn't mind, but definitely caution there. That brings me to understanding how to assess it intraoperatively. There's a lot of different ways this can be done. In the long cassette, traditionally with a plain radiograph, if you have an O-arm, they can do a 2D intraoperative CT scan, which is a really, really nice feature. And then if you don't have those long x-rays or if you don't have the O-arm, you can use this T-bar method, which is you make a rod, you have a rod, you put a lateral connector, you connect a domino, and you put another rod up. Then you take an AP x-ray of the pelvis, you put it on top of the sourceals, and then you go to the cervicothoracic junction and you take another AP and you see what the deviation is of the C7 plumb line relative to that rod, and that will give you your overall coronal alignment. Now, if the patient has a leg length discrepancy, you need to tilt this rod, the bottom of the T, so that it's the same angle relative to the floor that the leg length discrepancy is. And I can show you a patient next who had a leg length discrepancy and where we had to dial in her correction based on the horizontal and not on her leg length. So this is a lady, multiple surgeries. You can see L4 to S1 posterior, fused flat. She had adjacent segment problem. They did an ALIF. Again, now she's flat from 3 to 1, and now she's developing a coronal decompensation to the right, and she has a leg length discrepancy. So I won't go into the nuances of it, but we did an L5 asymmetric PSO, mainly to restore her low lumbar lordosis. We didn't want to do the PSO around that plate or even higher because of the sagittal distribution of the lordosis, and we dialed her into the horizontal and not towards her sourceals, and overall corrected her within the threshold coronally of 2 centimeters, kept her shoulders balanced, and she was quite happy. So in conclusion, coronal malalignment is common. Disability, we believe, is driven by greater than 2 to 3 centimeters of residual post-op coronal malalignment. You need to tailor your surgical strategies to the deformity. OBIE type 1, BOW type Bs, the concave types, the correction should be at the mid-lumbar curve. OBIE type 2, or the BOW type Cs, or the convex types, all the correction should be at the lumbosacral fractional curve. Intraoperative assessment is important to optimize postoperative alignment. So thank you, and happy to take any questions.
Great job, Alekos. Very thorough. I guess one paper you missed was mine on the importance of leveling L4 out. And so we found that if you level L4 out, that had the largest driving force in terms of maintaining coronal alignment. That was just a small series from our group. But I think those are very important points. And I think one of the important points I was going to ask you about is what to do with a leg length discrepancy, and I think you just showed it at the last case, and I think that's an important just to the patients, unless you're going to fix their legs, most likely they're going to be uneven, and so it's pretty important to know and go level to the floor like you're saying at that point.
I will include your paper in the talk moving forward.
I want to thank you for this talk, and you did a great job presenting this previously at our 1-hour Interesting Spine Case conference and national audience. And yeah, everybody who said Dr. Lewis's paper is the reference. No, but the point is, one of the biggest challenges I find in coronal deformity patients, aside from them frequently having a neuromuscular problem that you hinted at, is the lateral ascesis that these people have. So these 25+% lateral drifts. Any tips and tricks of how to get that vertebra stacked onto the normal vertebra again?
Yeah, that's a great point. That is, that can be challenging. And I personally think that's part of the reason I do the crushed allograft chips at 3-4, but a lot of times that translation's at 4-5, where I do like a structural cage. I tend not to try to overstuff that with a big cage, and I do think that if you put a cage in that provides enough lordosis, but it's not too rigidly fixed, that when you go from the back, there are ways that you can shift over that L4 vertebra. But happy to hear what other people's maneuvers are to correct that.
Dr. Lewis?
Oh, I agree. I think that usually there's a huge tilt at 4-5 and a translation at 3-4, as he's saying. And I usually correct the tilt. So my first step is to actually distract 4-1 or 4 to pelvis on the concave lumbosacral fractional, level out 4, and then I do the rest of my surgery. Okay. And so I find it quite effective.
Yeah, I think that especially if you're trying to do a shorter construct for someone you don't want to do a big correction on, that lateral ascesis is an important thing. And you know, with the intradiscal techniques, you can just see it move in person, and then you know, so you can get some correction through it, and then obviously tying that in through the bigger deformity, I think has been pretty effective. One of the things, you know, I find that you know, making the decision to do a kickstand rod in a bigger deformity, very powerful tool. Every once in a while, I'll not think that I need it, and then, you know, not get the coronal correction that I was hoping for intraoperatively and be kind of stuck. Do you feel like it really needs to be planned out ahead, or can you, you know, kind of audible and put that in later in your surgical plan?
Yeah, great question. So my use of and type of pelvic fixation has evolved over time, and I used to just do one on both sides and then only do a kickstand rod and add that iliac screw on the type Cs or the OBIE type 2s. I'd recommend that for all of them, even though you may not need it. Most of the time you do. But now I put dual iliac screws on both sides, and so I'm always ready for it, no matter what side it occurs on. With the S2AIs, I don't know how people set up their kickstand rod if they just have two two S2AI screws, just because it crosses the pelvis and fixes the sacrum. So I think you always need some traditional iliac screw to do a kickstand rod.
Yeah, in some of those cases, I will use an S2AI and iliac in the same. If you plan them out well, I think there can be enough room. But yeah, that's definitely a reason not to use the two SI joints, because S2AI type screws.
I think if you're going to even think about using it, you should just set it up from the beginning, because after everything's been corrected and then you have to go back in and go back down the pelvis, put another screw in, it's just not a very friendly, time-efficient way of going through your operation.
Alekos, great talk and great corrections. And I totally agree with you regarding the pendulum having swung, and you most importantly pointed out how the coronal alignment was maybe even ignored for a little while. Obviously in mixed deformities with sagittal and coronal deformity, you need to correct both, and you're doing that. Have you seen a shift in your thought process for an adult that needs a de novo surgery that does not have sagittal deformity but has coronal deformity and has issues? Have you been more aggressive in treating adults with pure coronal deformities, knowing the things that you know? And do you think the pendulum on that aspect has swung in your indications for that?
Yeah, that's a nuanced question. And a lot of times, the majority of the issues are in the distal lumbar spine, so L4 to S1. And I still will do just lumbosacral fractional curve corrections, mainly to help reduce or to improve radiculopathy. And if you can do the right surgery to correct that distal coronal deformity, and you correct their sagittal plane too, you kind of, it's the sweetest spot. You help them in two regards. So it is case by case though, and I try to tailor the surgery to their pathology. A lot of times, if the mid-lumbar curve doesn't have any stenosis, not causing any anterior radiculopathy at L2, 3, and they're overall coronally aligned, but really the issue is distal, then I don't necessarily think I have to correct everything, but I do try to correct that distal so that it will be balanced with the mid-lumbar one, so then it doesn't tip them over globally. But it is nuanced.
Great. Thanks a lot.
Thanks, guys.
We'll go to the lab. We're a little behind. Roland, you're all set to go?